Good evening and welcome to IHW Council's special web series on women's health, START, supporting treatment in assisted reproductive therapy. I'm Anisha Nair Dhawan and you're watching our exclusive show on women's health supported by Bharat Serums and Vaccines under its public awareness initiative. This is the second show in our special series to mark Infertility Week, where we are bringing in experts to help address some issues that could hinder your journey to parenthood. We are currently seeing the COVID-19 second wave in India a year after its initial outbreak. Now, this is just a reminder that we cannot put our guards down. We have to ensure masking, washing hands, and social distancing. This is also a reminder to put your health before anything else. Now, the arrival of the vaccine and the start of the inoculation process, as well as the lessons from last year, have brought hope to millions who want to stay safe and bring about a semblance of their pre corona days. But there are many others who find themselves in despair as some of their dreams have suffered a setback because of the many restrictions of lockdown and the fear of COVID 19. I'm talking about couples who dream about starting their family but are unable to do so because of infertility. Infertility over the years has emerged as one of the most common health issues that many young couples are facing. According to the Indian Society of Assisted Reproduction, infertility affects about 10 to 14% of the Indian population. The scenario is worse in our cities, where one in every six couples is impacted. Our show is special today as we are going to treat all aspects related to fertility and IVF treatment. Bharat Serum Vaccines Project Start is an initiative that aims to provide support to couples beyond medicines with initiatives like microfinancing and counseling. Project START encourages couples to stay on course for IVF treatment to achieve their goal of parenthood. Today, we'll be talking about low AMH and can you still get pregnant? There may be many questions in your mind on what you can do to succeed when it comes to starting a family. On our show today, we have an expert joining us to help answer all your queries. Please welcome Dr. Hrishikesh Pai, Medical Director, Bloom IVF Group. He's one of the best known IVF doctors in our country. Thank you so much, Dr. Pai, for joining us.
Thank you, Anika. Thank you.
Now, before I begin our conversation, I would like to request all our viewers today to start sending us your questions in the comment box. Just type in your question and we'll try to take up as many as we can over the next 30 minutes. This is your golden opportunity to get your questions answered by an expert who is with us now. Dr. Pai, let's begin. Now, AMH, say about 10, 15 years ago, when we used to test women, when we came for infertility, we checked LH, FSH, and, the hormone profile. AMH is a new addition. And with this new addition, if the results aren't very good, say you have a low AMH for a woman who is not very, very old, suddenly there is a fear that, oh no, this is the death knell in my, parenthood journey. Now I cannot have a child. How true is this belief?
So thanks for inviting me first and foremost, and I'm happy to answer all your questions and the patient's questions as well. So AMH means anti-Mullerian hormone. The short form is AMH, and it's a relatively newer test, maybe 5-10 years old. And we normally can do it on any day of the period. Normally LH, FSH tests have to be done on second or third day of period, but the advantage of AMH is you can do it on any day of the menstrual cycle. And then once you do it, the normal range is 2 to 3.5 nanograms per ml. There's another denomination also. It's called picomole. Some of the labs, they give the report in picomole, and a very simple formula is to divide the picomole value by 7. So if there's a 3 picomole divided by 7, that is 7 whatever is the actual nanogram per ml. So a normal range of AMH is 2 to 3.5 nanograms per ml in a woman who has got a normal ovarian reserve. The AMH is 2 to 3.5. If she's got a poor reserve, the AMH is less than 1.5. 1.2, some people consider 1.2, but okay, 1.2 to 1.5 level would be and a high AMH level is more than 3.54. Normally, a high AMH level is seen in PCOS patients, the polycystic ovarian syndrome, and many of the North Indian patients, due to their diet, genetics, lifestyle, have got PCOS. So they have a high AMH level, which I see a lot in my I have practiced both in the north as well as in the west, in Lilavati in the west, in Fortis in the north. So I see different background people, and there's a lower AMH is seen more amongst almost every state of society, but high AMH is definitely seen in the northern India people. So if there is a low AMH, there are a lot of other reasons for low AMH, which we need to first rule out. So suddenly if a patient who comes to me, say at the age of 20, let's say 32, and she has got a low AMH, that doesn't mean anything. She doesn't have to panic first and foremost, because I've seen a lot of people with low AMH at the younger age group, they become pregnant on their own. It's not that they don't. However, it's like a warning signal. Okay, I have a low AMH. First and foremost, you need to repeat it to see whether the laboratory result is correct or not. And if you repeat it and you still confirm it, then you know that, okay, what it gives you, its signal is that you need to get pregnant faster. So that is very important.
So, Dr. Pai, you're saying that AMH is actually a measure of the ovarian reserves.
Right.
All women, when in their mama's wombs, were blessed with X number of eggs, and that doesn't change. And AMH just shows how many are remaining and, what kind of chance you stand for pregnancy. So you said for younger women, a lower AMH does not mean that they won't get pregnant. So
yeah.
Why do women get so scared or so crestfallen when they
because they correlate it? So yes, low AMH. So what I feel is that AMH is a good, for a semen test is a good, like a screen for example, a couple is there, they get married. So let's classify it into two parts: a married woman and an unmarried woman. So if a married woman comes, they get married at the age of 32. They want to plan a pregnancy. They don't want to get a kid immediately. They should do an AMH level. She should do an AMH and an ultrasound level. If there's any gross problem in ultrasound or a AMH level is low, then they should try for a pregnancy faster. On the other hand, if the AMH is normal, then they can wait for 1-2 years and then try for a pregnancy. That's as far as the young couple is concerned who is married. Now, on the other hand, if there's a young woman, let's say 32 years of age, and she comes to me and she says, "Oh, I don't want to get married, and I want to, but at the same time, doctor, I want to check whether everything is normal. I'll still do an abdominal ultrasound for her if she's not sexually active. If she's sexually active, I'll do an internal ultrasound, and I would also do an AMH level. If the AMH is lesser, then I would tell her, okay, repeat a level. If that is still lesser, I would look for a cause, and then I would suggest her to get her eggs frozen. Okay. Preserve her fertility. And if suppose on the other hand, if she's married and if the AMH is lesser, then I will tell her to get pregnant as soon as is possible.
All right. Could you tell us then what leads to low AMH? I mean, you're blessed with the eggs that you have, but like you said, at 32, one woman may have a normal AMH and the other may not. So why does the poor lady with a lower AMH have a low AMH? What leads to this?
Right. So as you said that when you're in your mother's womb, there is a definitive fixed amount of eggs that are there, which you inherit, which are in your ovary. And after the puberty, every cycle, many of these eggs, they grow and they get destroyed on their own. It's called atresia. So because of that, every month, slowly the ovarian reserve falls down. And at a point in time, somewhere between the age of 40 and 45 or 50, when there is very little eggs in your ovary, then at that point, you will stop getting your periods. Because a low AMH means less eggs in your ovary, less eggs means less estrogen. And at one point in time, when the estrogen output from the ovary goes down, you suddenly become menopause. So that is a natural process. But if suppose if you get a menopause before the age of 40, it is known as premature ovarian failure or premature ovarian insufficiency. And many of these patients, they start having low AMH right from beginning before the age of 35. Now, if there's a low AMH before the age of 35, we need to look at the causes. So most of the time, there is no cause found. But in our country, one of the big diseases that can cause low AMH is tuberculosis. So that genital tuberculosis can damage the ovary and eat up the ovary, and that can result in lower ovarian reserve. The other common cause which has been seen nowadays amongst our lifestyle is changing. is endometriosis. So if you have an endometriosis also, especially there's an ovarian endometrioma, that also can eat up into your ovary. Or whenever you have such endometrioma, many times the surgeons, they go in and they try to remove the whole endometrioma. In the process of removing the surgery, they also remove normal ovarian tissue. And that's how the ovarian reserve goes down. So, and then there are other things like you may have a genetic problem which is called a Turner's syndrome or a Turner's mosaic, or sometimes you may also have a genetic disease called a fragile X syndrome. A fragile X syndrome, patients also, 4 to 5% of fragile X patient syndrome patients, they manifest as a low AMH. Sometimes if you have a thyroid inflammation, thyroiditis, that can also cause low AMH. But overall, if you investigate the patient, majority of the time you don't find any reason for low AMH, and most of the time it is called idiopathic, means we can't find a cause. So it's just genetically programmed that certain women have a tendency to go for an earlier kind of depletion of their eggs, resulting in earlier menopause.
Right. But Dr. Pai, you said that in your practice, you have seen that women with PCOD have a high AMH. So you can't even go and say, oh, I have a high AMH, I have a good chance of pregnancy, because PCOD, again, they are immature eggs, and many a times you do not have success in naturally fertilizing them on your own. So is there a gold standard of AMH number? Should people put a lot of emphasis on it?
So the gold standard is 2 to 3.5, but PCOS patients, when they come to me, I always tell them that you're an easy patient because with IVF, most of the PCOS patients, they achieve pregnancy. Our challenge is the patients who have low AMH. So I personally, I was just yesterday, I was conversing with someone. So I said everyone should have a routine. As soon as you get married, you should do 3 things. The wife should do a routine ultrasound and an AMH level, and the husband should do a semen test. If they are normal, you can plan your life and say, okay, if they come abnormal, then you should go for early child. And especially an unmarried girl, if suppose she crosses 30, before 30, I don't think you should really panic. But after 30, if you are not getting married in too soon, then you must do a AMH test. So if you have a low AMH, just today in the afternoon, I had a patient, lawyer girl, 28, she said she wants to freeze her eggs. So, like now they are white. So, you were talking about COVID. In over Europe and United States, suddenly there's a huge boom in the freezing of eggs during the COVID time. Because, abroad, the boys and the girls used to meet socially over in the bars or in the pubs or in the discotheques. So they are not meeting anymore. So, the relationship building used to happen in a social plane. So suddenly the women have become very panicky abroad. So they suddenly have no access, and because if they don't have access, then they can't get later on married and all. So there is a huge, there is like an outbreak of egg freezing in
but they
US.
Want to preserve their fertility.
Suddenly they have become very insecure, and there's a major, it's like an outbreak. There's huge, which we have not seen in India so much. I have not seen it.
That is also perhaps because there isn't so much awareness about egg freezing, and there may be some social stigma of unmarried women doing this. We'll of course discuss that later, but we've already started getting some queries from viewers who are watching. So one Facebook user is asking, how much role does mental mindset of the patient play in the success of IVF?
Success of IVF mental is very important. In fact, a lot of patients of mine, when they have their first baby, second baby, they don't need IVF. They are so happy they become pregnant on their own. So the stress is a major player in IVF. In fact, there are a lot of clinics in abroad which they do, and we have just started a similar clinic in Delhi, in the middle of the city, where they do fertility practice without IVF. They say we will get you baby without IVF. So one of the important things they do is they do lifestyle modification, they do weight loss. Your BMI means body mass index, which is weight in kilogram divided by height in meters square, should be between 18 and 24. If you have that ideal BMI, you have a very high chance of becoming pregnant. Your lifestyle, they do de-stressing, they do acupuncture, they do yoga, breathing exercises, mindfulness exercises. All these things, they not only increase the spontaneous pregnancy rate. But even if you're going for IVF, if you do all these things, IVF results will also improve. So the stress plays a major role in everything in life, I feel.
All right. So stress is the one thing that you 100% want to avoid if you're looking to start your parenthood journey. We have another Facebook user.
And before I say one more thing, the new ERT bill that is coming in India, it is compulsory for counseling to be done prior to IVF.
Now, who does this counseling, Dr. Pai?
So, and the government has with the new law that is written, it has to be done by a counselor who is not employed. Like, for example, if I'm doing the IVF, I should not be employing the counselor. Otherwise, the counselor will say all goody things about me. Okay. So he has to be a counselor who gives a proper, very
unbiased opinion
kind of counseling. Counsel them like, you will say, paint a rosy picture and say, oh, everyone will become pregnant. So they have to give a proper picture that the success rate of IVF is 30-40% per attempt. You need 3 attempts to get 70-80% pregnancy rate. So all this is done abroad. In our country, it's at present a little bit of Wild West, but with all these new regulations that will come in, all that will be standardized.
All right. Dr. Pai, another Facebook user is asking, I've had 3 IUI failures. Please suggest if I should go for IVF or should I wait for one more cycle of IUI?
So, I would like to say that, in the good old days, because I have been doing infertility practice for 30 years. So, in our country, one of the major players in infertility is infection. It may be a non-specific infection or it may be a tuberculous infection. And many times this cannot be diagnosed unless you do a laparoscopy. That is, put a scope in your tummy through the navel and see inside. So, I personally am from the old school. I feel that you should always do, suppose a patient comes to me, I would do an X-ray of the womb, which is very easy. Nowadays, you can even do some test. It is called hycosis. Once you establish the tubes are open, you can do 2-3 IUI cycles. However, if the X-ray shows a closed tube or an ultrasound shows some abnormality in the womb or in the outside the womb, or you have painful periods, scanty periods, then these are the patients who should be subjected to laparoscopy and hysteroscopy. And many times you can pick up infections, you can pick up adhesions. If you just do simple adhesivolysis, they become spontaneously pregnant. If there is a tuberculosis infection, I give anti-tuberculosis treatment for 6 months. While taking the treatment, they become spontaneously pregnant. So this particular, so in abroad, in the United States, they don't do so much of laparoscopy because the tuberculosis is not that prevalent. In our country, there's a huge prevalence of tuberculosis. And I have seen time and again, so many patients, they come to me with IVF failures and then they go for IVF and they fail with IVF. And then they come to me, I do a laparoscopy, correct something, and they become naturally pregnant as well. Mm-hmm. So we need to not break that sequence. I feel that in India, we should not break the sequence.
You would suggest more investigation to this Facebook user?
Yeah, so I would suggest a laparoscopy followed by 1-2 more IUIs, and if that fails, then go for IVF.
All right. We have another query. In IVF process, what are the chances for ectopic pregnancy? If it occurs, what could be the reason?
So in IVF, 2-5% incidence of ectopics is there. So we normally take the egg out, take the sperm, make the embryo and put it from below inside the womb. So you will say, how come there's an ectopic, doctor? Because after you put them in the womb, that can go into the tube as well, the embryo, and sit there. So especially if there's a diseased tube, previously like there's a damaged tube, the tube has got a lining and there are cilia. So there are cells which have got cilia like hair. They push the embryo back into the tube. But if the tube is damaged, these hair are damaged permanently. So they can't push the embryo back into the womb. So if the embryo by mistake goes and sits in the tube, it can't be pushed back. And that's why if there are diseased tubes, many times first we ligate the tube. Both of the side we block the tube, cut off the tube from the uterus and then do the IVF. And that's why it's very important when we do the test after the 14 days after the embryo transfer, we see the beta HCG level. And by looking at every 48 hours, the growth of the beta HCG level, you can pick up an early ectopic. And if you pick up an early ectopic, by simple injection, you can destroy. When you miss that early ectopic and then it becomes large at around 1.5 months, then it becomes very difficult to destroy it by an injection, and then you have to go by laparoscope and remove. So we use the monitoring of the beta HCG level to pick up that ectopic, and if we feel we confirm it with vaginal ultrasound, we will give an injection and destroy it.
But Dr. Pai, for somebody who's undergone IVF, it will be so heartbreaking to let go of, that much awaited pregnancy. So you were saying if somebody had already got themselves investigated by a lab and seen if their tubes were, patent, and if they didn't have any problem, the chances of them having come to this ectopic pregnancy would have been lower.
Yeah, Miss, if the tubes are abnormal, I didn't get your question.
The question is that before people plan IVFs, perhaps they should get proper investigation by a lab to see that, we don't come here.
Yeah, we need to investigate, especially if there's a hydrosalpinx, that is a tube filled with fluid. And on an ultrasound, if the tubal hydrosalpinx is larger than 2 centimeter diameter, you should remove those hydrosalpinx before going for pregnancy. And also that's why we should treat the infections and all that. But you can't really, you can't avoid it sometimes. And that's how it is. So if there is a previous ectopic, then we go purposely inside with a laparoscope, burn both the sides of the tube so that the ectopics will not occur in the next pregnancy.
Not recur again.
Yeah.
Okay. We have another question coming in from a Facebook user who's asking how to improve egg quality naturally.
So, there are a lot of people who have got this. See, now, as far as I am doing IVF for 30 years, so the normal responder AMH 2 to 3.5, no problem. In 3 attempts, 90% people achieve pregnancy. Hyper responder PCOS, very easy. In 3 attempts, they have got like dozens and dozens of eggs. I call them atom bombs. You give them injection, they'll develop 40 eggs at a time. So they are very easy to treat also. The problem is with the poor responder, AMH less than 1.2, 1.5. And that is the challenging. And many of the women are postponing getting pregnant. And I get a lot of patients who are 40-year-old, unmarried, and now they suddenly get up and they want to freeze their eggs. So now when you do their AMH, it is 0.3, 0.4. Then what do we do? So then we have to do rejuvenation of the ovary. So first of all, we do lifestyle. If they are obese, you reduce their weight. You can give them DHES, dehydroepiandrosterone, micronized DHS is given orally to improve the ovarian reserve. We give them other, micronutrients. I'm giving a talk some other day on micronutrients. So these are all supplements which are known to have very mild effect in improving the ovarian reserve. And then what we do is we also can, then we do IVF. When we do IVF on this patient, we may get 1 or 2 eggs. So we counsel them that we'll need to do repeated cycles, 3-4 cycles, and slowly collect the embryos and freeze them and collect them. It is called embryo pooling. And after that, we put them back. So that we can do. And sometimes they are really bad. 0.3 AMH, you don't get follicles only. Then we have ovarian rejuvenation technique. You can put PRP, platelet-rich plasma, into the ovary, or you can put stem cells in the ovary. These are all experimental, and very few, 10% people may actually respond to this kind of treatment. And now if that also fails, then as a last desperate resort, then we go for egg donation, where we borrow an egg from outside. And now within the next 7 years from now, we'll be able to make the eggs from the skin cells. So the skin cell egg making is already done in the mice, and already babies, mice babies are called pups. So mice pups have been born already. And the first work on humans has just been done last year in Japan. So the skin cell can be removed and it can be reprogrammed, reversed to become a stem cell, and that stem cell can be cleaved to become an egg oocyte. So this will be the future in 7. The other day I was listening to Dr. Sherman Silber, who has done a pioneering work in this, and one of the questions they asked him is, when will this be ready? He said 5 years max. 5 to 7 years, this technology will be ready.
Let's keep our fingers crossed, and let's hope there are no ethical issues involved there. Another question that we have is, does high AMH always mean PCOS?
Most of the time. There may be some, I am more of a practical doctor. Practical doctor means I'll get you the pregnancy. like I'm not too theoretical. I'm very practical. So as far as my knowledge goes, a high AMH level is PCOS. Simple.
Okay. All right. We have another question, Dr. Pai. How to increase AMH levels naturally?
So what are you asking me is how to increase the AMH level means ovarian reserve, because low AMH is because AMH is not low. The ovarian reserve is low and ovary produces AMH. So automatically the AMH becomes low also. So naturally, as I told you, the supplements are there. The most important thing is to do the prevention. Like in COVID, you do double masking, hand washing, social distancing, not to go to closed places like malls, restaurants. If you go to the malls, buy on the outside. If you go to restaurant, sit on the outside, don't sit inside. So similarly, the important thing is prevention. Freeze your eggs. That is the main thing, because the rejuvenation techniques are not up to the mark. Whatever you say, all these things, they don't give the result what we
So, Dr.
need.
Pai, this rejuvenation works at improving the quality or the quantity of eggs? Because I believe that the quantity of eggs is already fixed, and if you finish so many eggs, you finish so much eggs.
So overall, it is. No, I'm not happy with it. Let me tell you. Though I've done a lot of them, but I tell the patient I'm not really happy with it. It's like a. I mean, and the women, they undergo multiple cycles, and it's a bad situation which could have been tackled more preventively.
So you come early and you take proactive steps to preserve your fertility.
Yeah, you need to preserve your fertility, or you need to get have kids before. I feel you should have kids before the age of 35. Or if it is coming in the way of your career, preserve your fertility and have them later. But remember, for fertility preservation, minimum 15 eggs are necessary. So sometimes 1-2 half-hearted preservation is not good. Suppose you go for one cycle and you get 8 eggs, that's not great. You need the 15 eggs. And now there's a new artificial intelligence program which we are trying to acquire and get into India also, that we can actually, by looking at the eggs, the computer can predict which of these eggs will become embryos. So suppose we get 10 eggs and the computer says, no, only 5 are good, 5 are not good. We can do more cycles and preserve more eggs, so that the lady who preserves has an adequate good chance of fertility 10-15 years down the line.
All right. So, Dr. Pai, in conclusion, when we are discussing AMH, what would you advise viewers? When should they start seeing what the AMH is? How should they assess it? And, does it really become a hurdle towards pregnancy?
Right. So I feel I was putting at 30 is the cutoff age, but maybe I may go early also, 28, but we don't know. But because in India, most people get married early and all that. So maybe 28 to 30, we must do an AMH. If the AMH is low, you must do some important tests like thyroiditis, look for, blood tests, X-ray tests, look for tuberculosis, do a karyotyping and do a Fragile X syndrome test. It's called a PCR test. Rule out everything. And then you can, if you're less than 35, you freeze your eggs. And if you're married and less than 35, have kids quickly.
All right. Thank you so much, Dr. Pai, for joining us today and enlightening us with so much knowledge. You're always abreast of the latest technologies and what's coming up, and you give so much hope to everybody listening in that it only gets better thanks to science from here on. Thank you so much for joining us, for giving us your insights, and for answering the questions. Thanks,
Anisha, and thanks to the IHW and for the CSR activity that is being carried out by Bharat. Thanks a lot.
Thank you. So that was Dr. Pai answering all your questions on fertility and IVF treatment during COVID-19. Now, if you have more questions, you can still send them to us using our WhatsApp button. Just press it, the WhatsApp button on our Facebook page, and type in your questions. We will try to include them in our subsequent shows. And do remember, we are marking the Infertility Week. We are bringing in experts to help answer all your questions. So do use this opportunity. Also, if you feel that they may be your friends or family members who may benefit from these discussions, please share our page with them so that they're also abreast of what's happening. Don't forget to follow us and stay updated on all that concerns your health and well-being. This program was supported by Bharat Serums and Vaccines under its public awareness initiative. We will be back very soon, continuing our special series for Infertility Week. Do follow us on Facebook to get all the updates on our upcoming programs. Keep sending us the questions and we'll try to include them in our next show. Till then, stay at home, stay safe, mask up, and have a good evening. Bye-bye.